Tantor Audio, a division of Recorded Books, presents Psychopharmacology, Straight Talk on Mental Health Medications, 4th edition, by Joe Wegmann, narrated by Joe Wegmann. Publisher's Note: this audiobook includes bonus material. Please visit Tantor.com and type Psychopharmacology into the search box. Follow the link to the book's page. Then, under the Supplemental Content section, please enter the access code Biology, and then click the Unlock button to access the bonus material. The code should be entered in all lowercase letters. All figures and tables referenced in this audiobook can be found in the bonus material. The material presented in this book is for educational purposes only, and should never replace the advice or treatment plan of a physician or other healthcare practitioner. It should not be used for diagnostic or prescribing purposes. The author offers no endorsement of products, recommendations for drug dosing, or any implied promise of relief. Case examples throughout the book are for illustrative purposes only, and are not to be used as models for medication management of a particular disorder. Every attempt was made to present accurate information at the time of publication, but the subject of psychopharmacology is an ever-expanding one. The author assumes no responsibility or liability for any action taken as a result of the information contained in this book. What's inside? With medication management playing an increasingly pivotal role in the treatment of mental health disorders, the challenges faced by clinicians are increasing. For one, non-medical clinicians provide the majority of mental health services in the United States. For another, the majority of prescriptions and orders for psychotropic medications are written not by psychiatrists, but by family practice and primary care physicians. As a result, you may be working with patients who are neither in a program of monitored drug use nor being treated with a combination of medication and psychotherapy. Under these conditions, it is essential for all healthcare professionals, particularly those providing mental health services, to have a working knowledge of psychotropic medications. Ideally, medication prescribers and non-prescribers alike will work together to implement treatment strategies and improve clinical outcomes. This book follows a straightforward, user-friendly format. It provides a summary of the disorders routinely encountered: psychosis, depression, bipolar, anxiety, insomnia, ADHD, opioid disorders, marijuana use, and chronic pain, followed by a discussion of the medication management of these disorders. Key to the 4th edition is an in-depth discussion about which circumstances non-pharmacological interventions are the preferred treatment modalities, as well as recommendations for how to best utilize medication and psychotherapy in a complementary way. Pharmacotherapy in special population groups, specifically children and adolescents, pregnant women, and geriatric patients, are examined. With many people self-medicating with herbal remedies, dietary supplements, and vitamins, this book also outlines the herbal treatments that have proven beneficial in treatment and those that pose potentially harmful interactions with prescription drugs. The goal of this book is to guide you in practical and clinically relevant language through the maze of mental health medications, then help you identify ways to use your expanded knowledge to improve client outcomes. Throughout the text, the terms patient and client will be used interchangeably per the context of the discussion, but essentially mean the same thing. New to the 4th edition: the importance of developing client rapport, a more detailed look at depression and its origins, antidepressant strategies for the first-timer, behavioral activation therapy, the importance of getting clients moving, suicide and its rising prevalence, the emergence of ketamine for depression, antidepressant discontinuation, mindfulness, Spravato, the first really new and original antidepressant in more than 30 years, key questions to ask when assessing for bipolar disorder, lithium, Still the best after all these years. Anxiety treatment. What should not be medicated? Benzodiazepines. Still viable after 60 years. Much expanded section on insomnia. Opiates, opioids, and the crisis surrounding them. Chronic pain management. Update on the etiology of schizophrenia. Adult ADHD and assessing it correctly. New medications for ADHD. Updates on herbal and other alternative treatments. Talking to clients about psychotropic medication side effects. Telehealth treatment. Psychopharmacology, Straight Talk on Mental Health Medications, 4th edition, is a desk reference suitable for healthcare professionals and for anyone interested in expanding their knowledge of how to best manage mental health disorders, both pharmacologically and behaviorally. Joe Wegmann, New Orleans, Louisiana. Section 1. Getting Started with the Client. Chapter 1. The DSM, Medical Model, Neurobiology. Biological psychiatry focuses on understanding mental disorders from an organic standpoint. Specifically, it focuses on the functions of the human nervous system. The practice of biological psychiatry dates to ancient times, yet the term itself was not used until the mid-20th century. That's when research, creation, and the use of newly developed drugs intensified, resulting in new classes of pharmacological agents, including sedatives, antidepressants, and antipsychotics, which addressed mental health disorders. The DSM. Around the same time these new drugs were emerging, there became a clear need for a dependable body of knowledge that would assist clinicians in defining the approximately 100 diagnostic mental health categories used at the time. In 1952, the first Diagnostic and Statistical Manual of Mental Health Disorders was published. Better known by its initials, DSM, the guide is now in its 5th edition, DSM-5. With the arrival of the DSM, the emphasis shifted to more descriptive and biological models and treatments, and away from the psychoanalytically based models and treatments of Freud, Adler, and Jung. Theorists and clinicians who were more interested in the why of a disorder than its what. Also, where the older psychoanalytic models tended to classify individuals, the DSM classifies disorders. We used the DSM to compare the signs and symptoms of our client presentations through a set of objective criteria. The DSM serves as a guide to clinical practice by helping clinicians define disorders more consistently. This, in turn, allows for a better prediction of prognosis and treatment response. The DSM-5 was in development for more than 10 years. Its official release was announced in May 2013 at the American Psychiatric Association's annual meeting in San Francisco, California. New diagnoses have been added and others have been amended or combined. Some proposed criteria considered for inclusion stirred up so much public and professional ire they were eventually eliminated from the final draft. The most noteworthy changes to the manual are concept-driven. The multi-axial system of the previous DSMs has been dropped in favor of a dimensional diagnostic scheme. This new format combines the former axes 1, 2, and 3 with separate notations for psychosocial and context factors, formerly axis 4, and disability, formerly axis 5. Also, the chapter order is different and other disorders have been grouped. The furor surrounding the DSM-5's changes, particularly its additions, has subsided for the most part as of this writing. However, in the first 6 months after its release, proponents and opponents of the guide's changes eagerly held their ground, defending their positions. I have conducted my own thorough independent review of the DSM-5, so here's my take on its positives and negatives. Positives. The DSM-5 has tightened up criteria in the best interest of patients. The multi-axial classification system needed to go. Most of us practice professionals used axes 1 and 2 all but exclusively. Mental retardation is no longer being used as a diagnosis and is being replaced by intellectual disability. This change comports well with established practices in the field. Autistic disorder is gone as a diagnosis and is replaced by autistic spectrum disorder. Also gone is Asperger's syndrome. This is a good move because the spectrum concept provides overall better usefulness for the autistic disorders as a group. Another positive change is the reorganization of disorders such as obsessive-compulsive disorder and post-traumatic stress disorder. Anxiety is not the root cause of either of these disorders. Therefore, these syndromes have been regrouped accordingly as a reflection of clinical advancements aided by neuroscience. In the schizophrenia arena, the 5 subtypes, disorganized, catatonic, undifferentiated, etc., were nixed because they were largely ignored. Negatives. Disruptive mood dysregulation disorder, DMDD. This diagnosis morphed out of the overdiagnosis of bipolar disorder in youth. It is rife for serving as a diagnostic dumping ground for children by pathologizing what amounts to, in at least some instances, no more than temper tantrums. Oppositional defiant disorder is sufficient for this. And what's the chance that a clinician who is intolerant of unruly behavior will be quick to diagnose this and get paid by an insurance company? This is a mess waiting to happen, is untested, and opens another door for medicating kids inappropriately and excessively. Generalized anxiety disorder. This disorder has had shady boundaries since it was first included in the DSM. Now that the duration of symptoms has been reduced from 6 months to 3 months, it will be harder to distinguish what is truly a chronic disorder from the concerns of everyday life. This will create a sizable new subset of anxious people who may be unnecessarily treated with anti-anxiety medications, when all they are experiencing are the ups and downs of living life on life's terms. Bereavement exclusion. Widespread criticism emanated from the decision to eliminate the so-called bereavement exclusion, in which a grieving individual had up to 2 months after the death of a loved one without being diagnosed with major depressive disorder. This simply did not need to be meddled with. Grief is an absolutely normal human response to loss and should not be placed on the clock, so to speak. What's more, any competent clinician wouldn't miss the presence of major depression, even when occurring during bereavement. Mild neurocognitive impairment. Adding this condition makes it rather challenging to distinguish what is actually impairment from normal forgetfulness associated with aging, and runs the risk of pathologizing people with slight memory problems. We're going to get closer and closer to establishing a biomarker for Alzheimer's, so why not wait for something more definitive instead of having older adults do all sorts of testing that lacks specificity? Binge eating disorder. This disorder seems to be one of occasional overeating. Adding to the confusion is the quantity of food that might be excessive for a typical meal could be regarded as normal for a celebration or holiday meal. Why should context matter? Isn't overeating irrespective of when or where it happens? The psychostimulant Vyvanse, lisdexamfetamine, is approved for BED in adults. Attention Deficit Hyperactivity Disorder, ADHD. The DSM-5 has rendered the path to diagnosing ADHD easier than it has ever been. According to the Centers for Disease Control and Prevention, CDC, nearly 1 in 5 high school-age boys in the United States and 11% of school-age children have received a diagnosis of ADHD. There has been a 53% rise in diagnosis in those ages 4 to 17 in this past decade alone. The DSM-5 allows for symptoms to merely impact daily activities rather than cause impairment. Also, the requirement that symptoms appear before age 7 has changed to before age 12. My number one concern here is since every psychiatric syndrome on Earth adversely affects attention in some way, making it easier to go to ADHD means that other potentially important diagnoses may be overlooked. The DSM has served as a viable diagnostic guide for decades now, and its use as a teaching tool for graduate students and novice clinicians for understanding the process steps pursuant to diagnosis has proven to be most valuable. My overall assessment, though, is the diagnostic bar has been lowered, and people with bona fide psychiatric illnesses are already badly shortchanged from a treatment perspective due to our severely fractured mental health system. The DSM-5 will make this worse by directing scarce resources away from the very ill and toward people mislabeled as mentally ill instead. Medical model. Since the age of Hippocrates, medication has been used to manage both physical and mental health pathologies. The primary goal of the medical model is to identify these pathologies and then attempt to fix them. This is as true today as it was 2,500 years ago. Over time, 3 goals of pharmacotherapy have emerged. 1. To treat an acute disorder. 2. To prevent relapse after clinical improvement. And 3. To prevent future episodes of the disorder. More simply described, these are the acute, continuation, and maintenance goals of medication management. Acute treatment is initiated to ameliorate the symptoms of an actively occurring disorder. During this phase, the primary goal is to stabilize the patient using medication. Acute treatment begins with the initial prescribing of medication and generally lasts for a period of up to 6 months of prescribed use, according to the National Institute of Mental Health, NIMH. Continuation treatment is utilized to prevent relapse after the initial improvement. Here, the goal is to minimize the possibility of patient decompensation after stabilization. This period of medication use extends from 6 months to 1 year, as defined by the NIMH. Maintenance treatment is utilized to prevent future episodes of a disorder. 2 acceptable examples of this pharmacotherapy goal are the use of mood stabilizers for bipolar disorder and antipsychotics for schizophrenia. While the NIMH defines this phase as prescribed drug use for a period of 1 to 2 years, several disorders discussed in this book are linked to long-term and even lifetime prevalence of psychotropic medication utilization. Biology of psychopharmacology. Pharmacokinetics. Pharmacokinetics, or the study of what the body does to a drug, is associated with 4 basic processes: absorption, distribution, metabolism, and excretion. Absorption is the movement of a substance into the bloodstream. In other words, this is the process of a substance entering the body. Distribution involves the scattering of drugs or substances throughout body tissues and fluids. Metabolism is the transformation or breakdown of substances, preparing them for elimination from the body. Metabolism occurs primarily in the liver. Excretion is the process by which substances leave the body. Excretion occurs primarily through the kidneys. Pharmacodynamics. Pharmacodynamics is the science of drug action. Basically, it studies what a drug does to the body. More specifically, pharmacodynamics studies the mechanism of a drug action and the relationship between drug concentration and effect. The effects that any drug has on the body may be intended or unintended. In a perfect drug scenario, medications would zero in on only their intended target systems, generate only desired effects, then metabolize and leave the body. But as almost everyone who has ever taken medications knows, drugs have unintended and undesirable effects as well. In this sense, they take a shotgun approach rather than a rifle approach to the body. Hopefully, we get what we want from them, but at the same time, unfortunately, get some of what we don't want as well. For all of us, the most desired effect of any medication is its pharmacological effect, namely, does the drug actually do what it claims to do? Undesirable consequences of medication use include side effects, allergic reactions, rare yet potentially serious unpredictable events such as anaphylaxis, and the effects on the body if a drug is abruptly discontinued. Later on in this book, recommendations for the dosing and scheduling of medications in special population groups, such as expectant mothers, children, adolescents, and older adults, will also be discussed. Yet another challenge facing prescribers in the future will be how to appropriately address the way that different ethnic groups respond to medication. There is evidence suggesting that several psychotropic medication classes are metabolized differently, thereby producing different response rates when prescribed to African Americans and Asians, for example. This suggests that accepted dosing practices may require modification when prescribed to those in different ethnic groups. Drug interactions. A detailed discussion of the various types of pharmacokinetic and pharmacodynamic interactions is beyond the intent of this book, but it's beneficial to have a working knowledge of what happens when drugs enter the system. It's also important to understand their effects on other drugs and even foodstuffs also consumed. Pharmacokinetic interactions involve the absorption, distribution, metabolism, and excretion processes described earlier, or more specifically, what the body does to a drug. Drug-food interactions are more prevalent than drug-drug interactions during the absorption process. For example, the absorption of the antipsychotic drug Geodon, ziprasidone, discussed in Chapter 8, is slowed if taken without food. Thus, Geodon, ziprasidone users are advised to take the drug after a meal. An example of a distribution process interaction would be taking Depakote, divalproex, discussed in Chapter 12, and aspirin together. In this instance, aspirin displaces a portion of the Depakote divalproex from its protein binding, causing the unbound Depakote divalproex portion to increase, resulting in increased Depakote divalproex levels. During the metabolism process, drugs are broken down by enzymes in a number of different ways to facilitate their elimination from the body via either the urine or feces. An excretion process example would be the use of lithium together with caffeinated beverages or energy drinks. Caffeinated coffee or tea accelerate kidney function and can lead to decreased lithium levels. Pharmacodynamic interactions involve the effect that drugs have on the body when taken together. An example would be the use of a benzodiazepine drug such as Valium, diazepam, taken together with an antihistamine drug such as Benadryl, diphenhydramine. Each of these taken separately can cause drowsiness, but when taken concomitantly, the user can become markedly drowsy. Both drugs are discussed in Chapter 13. Interactions happen because of misinformation, misuse, or in instances where little or no guidance is provided at all. Interactions among drugs, foods, or medicinal plants and herbs run the gamut from benign to potentially fatal. Fortunately, very few are lethal, and many drug-drug interactions can be managed via dosage titration upward or downward. The major risk factors are toxicity when drug actions are synergistic, and a lack of therapeutic efficacy when actions are antagonistic. And of course, there's the ever-present risk of worsening side effects when drugs are combined. Psychotropic medication-drug interactions worth noting. Antidepressants, antipsychotics, and some of the older anticonvulsants are linked to significant drug interactions. Be on alert if your patient is taking any of these drug classes. Be on alert for the drugs with narrow therapeutic indexes, namely when the toxic dose and the therapeutic dose are in close proximity to one another. Examples include lithium, Tegretol, carbamazepine, as well as medications often used in physical medicine, such as the blood thinner warfarin, the cardioactive drug digoxin, and the anticonvulsant dilantin, phenytoin. Be aware that the risk of drug interactions increases as the number of medications the patient is taking increases. This can be of significant importance in elderly and pediatric populations. Neurotransmitters. Neurotransmitters are chemicals associated with a complex series of nerve pathways that regulate what we humans think, feel, and do. Medical experts have identified as many as 50 peptide neurotransmitters that have been shown to exert their effects on nerve cell function. There are probably many more yet undiscovered, since the brain contains approximately 100 billion neurons, or nerve cells, that are regulated by these neurotransmitters. The 6 neurotransmitters that are most important to psychopharmacology are norepinephrine, serotonin, dopamine, gamma-aminobutyric acid, GABA, acetylcholine, and glutamate. Norepinephrine, noradrenaline, is a hormone secreted by the adrenal glands in response to stress or arousal. It is the principal neurotransmitter of sympathetic nerve endings, supplying the major organs and skin. Norepinephrine regulates alertness, anxiety, tension, and the ability to have positive feelings. It is also linked to the mobilization of the body's resources during the activation of the fight or flight response. As such, it is released in response to an imminent danger or threat, resulting in an increase in heart rate, blood pressure, and respiration. Elevated levels of norepinephrine can lead to states of increased anxiety, and in some cases, mania. Low levels of norepinephrine are implicated in depression. Serotonin is a vasoconstrictor present in blood serum that is linked to the regulation of mood, anger, aggression, anxiety, appetite, learning, sleep, sexual functioning, states of consciousness, and pain. Low levels of brain serotonin are associated with clinical depression, obsessive-compulsive disorder, and anxiety disorders. Selective serotonin reuptake inhibitors, SSRIs, a class of antidepressants specific to serotonin regulation, will be discussed in Chapter 9. Dopamine influences emotional behavior and cognition, and it regulates motor and endocrine activity, among other factors. It has numerous important roles in brain function, including attention, mood, sociability, motivation, desire, pleasure, and learning. Dopamine is also strongly associated with reward mechanisms in the brain. Unusually high dopamine action can lead to psychoses and schizophrenia. Many antipsychotic medications are formulated to block excess dopamine. Gamma-aminobutyric acid, GABA, is an amino acid that is the central nervous system's major inhibitory neurotransmitter. GABA regulation is associated with emotional balance, sleep patterns, and anxiety. Low GABA levels in the limbic system, the emotional brain, are associated with increased anxiety, irritability, and agitation. GABA activation results in decreased anxiety. This process can be facilitated through the use of benzodiazepine anti-anxiety agents, including Ativan, lorazepam, Xanax, alprazolam, and Valium, diazepam, as well as through the use of mood-stabilizing neuromodulators such as Tegretol, carbamazepine, and Depakote, divalproex. All of these drugs act to calm overall brain excitation. Acetylcholine was the first neurotransmitter to be identified when it was discovered in the early 1900s. This neurotransmitter is released through the stimulation of the vagus nerve, which alters heart muscle contractility. Acetylcholine is also important to functional memory and has been the subject of much of the research investigating cognitive dysfunction and memory deficits linked to Alzheimer's disease and other organic brain syndromes. The inhibitory or blocking actions of certain antidepressants on acetylcholine will be addressed in Chapter 9. Glutamate is the brain's primary excitatory neurotransmitter. It is a basic building block of proteins and plays...
Sample complete. Ready to continue?